Hello, everybody. I'm Frédéric Millot from Poitiers in France. I'm very pleased to present today on behalf of the CML committee of the I-BFM study group the treatment recommendation in pediatric CML chronic phase, and I would like to thank the International CML Foundation for this opportunity. Regarding chronic myeloid leukemia, there are three phases: the chronic, accelerated, and blastic phase. There are various definition of the phases, and reported here on this slide the European Leukemia Net criteria regarding accelerated phase in terms of blast, 15 to 29%, and blastic phase, more than 30% of blast. Recently was published in 2022 an international consensus classification with different level of blast phase, of blast in the blood and in the bone marrow, with the definition of accelerated phase with 10 to 19% of blast and more than 20 for blastic phase. Now, regarding the European Leukemia Net recommendation published in 2020 in leukemia regarding the adult patient, the main goal of the treatment is to achieve survival equivalent to the general population with first-line treatment with tyrosine kinase inhibitors in CML in chronic phase, and treatment-free remission is another goal. Treatment-free remission is defined with the possibility for patient in deep and sustained molecular response to discontinue the treatment. And finally, regarding the pediatric aspect of the disease, there are some differences in terms of clinical and biologic characteristics leading to the creation a few years ago of the international group, pediatric group, in order to set up some recommendation. Tyrosine kinase inhibitors represent the first line of therapy for children with CML in chronic phase. And I would like to remind you the various steps to achieve in order to be efficient with such therapy. In terms of hematologic response, to achieve, to obtain a complete disappearance of the splenomegaly and the normalization of the blood counts. In terms of cytogenetic response, to achieve a complete cytogenetic response, which means the complete disappearance of pH-positive mitosis, and in terms of molecular response, defined with the ratio BCL to ABL according to the international scale, to achieve a major molecular response, define the ratio less than 0.1% of a deeper molecular response between MR4 to MR5. This slide to illustrate the fact that results with imatinib are quite similar in adult and the pediatric population. Here I reported the main prospective study in adult, comparative study with imatinib and another tyrosine kinase inhibitors, and here the two prospective studies in the pediatric population, the French one and the German study. And you can notice that in terms of complete cytogenetic response, 12 months after imatinib, the rate of CCR is quite similar in this pediatric population and the adult population. Same trend for the major molecular response, 12 months after the start of imatinib. This is an overall survival curve regarding all phase of CML according to the German experience, with the result of the prospective study conducted by Millot and published in 2018, with an overall survival of more than 94%. A few years ago was discussed the problematic of the generic formulation of imatinib, and Millot published in 2018 the fact, after discussion within the international pediatric group, that branded imatinib is preferred because no data on generic imatinib pharmacokinetics are available in children and adolescents. I have mentioned imatinib, but there are two other drugs, two other tyrosine kinase inhibitors available on the market regarding tyrosine kinase inhibitors, and dasatinib, second generation tyrosine kinase inhibitors, and I reported here the result in terms of major molecular response 1 year after the start of dasatinib, and you can notice a major molecular response rate of about 52%, which is quite higher than with imatinib. Same trend with nilotinib, a second generation tyrosine kinase inhibitors, with a major molecular response rate 1 year after the start of nilotinib of about 64%. There is no specific prognostic score in the pediatric population, and I reported here the publication we made in 2017 regarding prognostic discrimination in children according to the prognostic scores used in adults, the Sokal score, the Euro score, the UTO score, and the ELTS score. And we demonstrated that the ELTS score can better discriminate patients with high risk of progression in this pediatric population. And so ELTS score can be used for the stratification of the patient in the pediatric cohorts. I reported many years ago the impact of the decrease of the transcript level, with a ratio at 3 months, more or less than 10%. And as in adults, we demonstrated that the rate of major molecular response is higher in patients with less than 10% of ratio at 3 months after the start of imatinib, and with higher progression-free survival in this patient with a ratio less than 10% at 3 months. And this is one of the cornerstones of the strategy in this pediatric population as well in adults. On this slide is reported, it's a heavy slide, with proposition of a treatment algorithm for patients less than 18 years with newly diagnosed CML in chronic phase according to the 2020 and 23 ELN targets. Can propose as frontline therapy imatinib 300 milligrams per meter square, maximum dose 400 milligrams, and it's possible to propose second generation tyrosine kinase inhibitors in patient with high ELTS score at diagnosis. A peripheral blood assessment of the ratio BCL-to-ABL is performed at 3 months, 6 months, and 12 months after the start of the tyrosine kinase inhibitors, and the optimal response is defined with a ratio less than 10% at 3 months, less than 1% at 6 months, and less than 0.1% 12 months after the start of the treatment, the tyrosine kinase inhibitors. In this patient, the frontline therapy is continued, and after 12 months, it's necessary to check the persistence of a BCR-ABL ratio less than 0.1%. And in this patient, it's possible to continue therapy indefinitely, but it's possible to propose a treatment-free remission if the criteria are fulfilled. Here are the propositions regarding treatment-free remission in children under imatinib, and proposition in discontinuation in patients less than 18 years at diagnosis in chronic phase exclusively, without no previous progression, without failure or warning, and no previous allogenic stem cell transplantation. A treatment duration of 3 years is mandatory, with deep molecular response with at least MF4 for a duration of at least 2 years. And close monitoring after discontinuation is proposed with a monthly assessment of the ratio BCR-to-ABL, and after 6 months, every 2 to 3 months. A warning is defined with a patient who present at 3 months ratio of more than 10%, at 6 months between 1 and 10%, and at 12 months after the start of TKI, a ratio between 0.1 and 1%. In this patient, dose escalation of imatinib can be considered if plasma level of imatinib are less than 1 nanogram per ml. If in case of a plasma level of more than 1,000 nanogram per ml, it's possible to continue on frontline therapy until the achievement of a ratio less than 0.1%. In case of non-achievement at months 18 to 24, or loss of a ratio less than 0.1%, a switch to a second or the third generation tyrosine kinase inhibitors or an investigation drug can be proposed. In case of resistance, the definition here with a ratio more than 10% at 3 and 6 months, and it's necessary when there is a ratio less than 10% at 3 months to confirm this rate of more than 10% within 1 to 3 months, and the resistance 12 months after the start of the treatment is defined with a ratio more than 1%. In this case, a switch to a second or third generation TKI or an investigation drug is proposed, with a selection of the drug based on mutational analysis in case of resistance. And in case of intolerance at any time, a switch to a second or third generation can be proposed, and the selection is based on the comorbidities or the side effect profile, in this case of intolerance. In case of non-achievement of BCR-ABL of ratio less than 0.1% after 3 lines of therapy, in case of progression to advanced phase, stem cell transplantation can be considered. On this slide is reported the main drug which can be used currently in children in phase 2 of phase 1 studies and the drug on the market. This is a three-dimensional representation of BCR-ABL, and you can see that there are 2 sites which can be targeted. The ATP binding site targeted by first generation TKI imatinib, second generation TKI nilotinib, dasatinib, bosutinib, and third generation TKI ponatinib. And recently was introduced the asciminib with which target the myristoyl pocket exactly here. There are, as mentioned, there are some phase 1 and phase 2 ongoing studies in children and adolescents. Phase 1 and phase 2 study with a second generation tyrosine kinase inhibitors, bosutinib, with third generation TKI, ponatinib, and with asciminib. And these studies are currently ongoing, and the date will be given at the next I-BFM meeting in the next May. This is my last slide. We set up a few years ago an international CML expert board in order to help to answer to complex cases. And to date, more than 18 cases were discussed from various countries. Here are reported the various question, supportive care, stem cell transplantation, treatment of advanced phase. And over a period of more than 50 months, worldwide counseling was given on about 1 children per month. Now, regarding CML in children, we have to better define predictive factor of TKI failure, to determine a prognostic score for the pediatric population, to better define the long-term effect of TKI and specifically the second generation tyrosine kinase inhibitors, to try to predict, to identify predictive factor for treatment-free remission success, and to improve the treatment of advanced phase. This needs an international cooperation and a lot of discussion among our study group. I'd like to thank you for your attention.